I'm going to talk about this project that we're doing on hepatitis C with our colleagues in rural Alaska. So first of all, hepatitis C is a virus of the liver that can lead to cirrhosis, cause liver to fail, and liver cancer to occur in person when they get this infection. Now, most persons who have hepatitis C aren't sick until their liver actually fails or they get liver cancer. And Alaska Native people, as well as American Indians, have the highest rates of hepatitis C in the US and also the highest rate of liver cancer of any racial ethnic group, with the exception of Asian Pacific Islanders in the United States. Now, the rate of liver cancer in Alaska Native people has doubled in the past 20 years, as I'll show you in a second. Now, how is hepatitis C spread? It's spread by blood contact. So currently, we have an epidemic of hepatitis C that's going on in Alaska and in the US, and it's related to the injecting drug use epidemic. But prior to 1990, before we had a test for hepatitis C, and before we learned that we needed in the medical profession and also in other professions, such as tattooing and body piercing and things like that, that we needed to use blood precautions, wearing gloves, making sure that we didn't give anybody any products that might be contaminated. A lot of people got infected by medical procedures, blood transfusions, because there was no test for hepatitis C before 1990 that could tell whether a unit of blood that was transfused actually was infected or not. And other blood exposures, and even body piercing, ear piercing was not completely safe. So we've corrected all that, as long as people go to licensed tattoo and body piercing parlors and they get a blood transfusion in one of our hospitals in the United States, they're safe. But we do have a lot of cases occurring from injecting drug use. So a lot of people who don't have a risk factor were infected before 1990. They don't know that they have hepatitis C, and they don't know that they should be screened for hepatitis C. So this just shows you how the number of cases of hepatitis C in the Alaska Native population has really risen since 2010. And it's mainly risen in people that were born after 1965. So because hepatitis C is such a big problem in the United States, it's an epidemic problem, the CDC is recommending that every adult who's between the ages of 18 and 80 be tested one time for hepatitis C, because they may have been infected before we knew that this virus was even present. And so therefore, how do we implement universal screening, which is which is recommended, not only recommended, but actually covered by Medicare, Medicaid, and private insurance? Now, the good news is that since 2015, we have these oral drugs, which I would call a miracle, literally miracle drugs, that can cure 95% of persons with hepatitis C with just 8 to 12 weeks of once a day medication. These drugs literally have no serious side effects. About a third of persons experience a mild headache, some tiredness, or occasional upset stomach. So the good news in this hepatitis C treatment revolution is that the treatment is short. There's few side effects, none of them serious. Cure rates more than 95%, dosing once a day orally, and minimal monitoring is really needed, meaning that people that aren't necessarily licensed providers could actually provide treatment under the supervision of licensed survivor. So these are the three drugs. You've probably seen them advertised on TV that are 95% effective. They're all oral drugs. The drug we probably use the most now is this drug, which is called Maviret, Lacacpravir and Preventasphere. It is the reason we use it the most is that it is the drug that Medicaid will pay for, and everybody can get treated because it turns out that if Medicaid or insurance is not available to that person, the company will actually give the drug for free for anybody that makes less than $100,000 a year or has less than $500,000 worth of assets. So that means that we literally can treat everybody, and our hospital and most of our tribal hospitals will, if that rare patient that has too much assets and doesn't qualify for the free drug, they'll pay for the drug for them through their pharmacy. And what's happening now in Anchorage is that the SCF has got a very aggressive program of treating persons with hepatitis C, and they're using the pharmacist to do most of the treatment after the provider sees the patient and writes the drug. And we usually see the patient also one time to check and see if they have any scarring in their liver using our FibroScan machine. And the regional tribal hospitals around the state, in the most part, are doing a great job of treating persons with hepatitis C. But where we're really having a problem is persons that live in remote communities off the road system, and for the most part, they're not able to get treated or even screened for hepatitis C. And we've already identified 184 persons that live in rural communities that need treatment and aren't getting the treatment. So there's many barriers that are access to treatment, as they need persons under the current way we treat need to make 2 to 4 trips to the nearest facility with a licensed provider and by plane oftentimes. And oftentimes these communities are more than 100 miles away from that provider. So that's an expensive proposition. And you can see that literally we have hepatitis C in just about every community throughout the state of Alaska. Now, what we would like to do is to bring hepatitis C screening and treatment to persons living in isolated rural communities. So this would be like a one-stop shopping. So we are working on designing a program to train community health aid providers to screen persons in their community, and we would treat them via telemedicine with specialists at ANTHC. So this treatment would get supervised by licensed providers, but the person wouldn't have to fly into the nearest facility 2 to 4 times, and furthermore, the regional health corporation would not have to pay for the cost if the patient did not have insurance. So we all know that the community health aid practitioners, which are the lifeline of treatment in rural Alaska, they receive a 16-week program. They're certified by the state of Alaska. So what we would have these CHAP persons do in the study villages that we're going to select, they would screen all residents from one time from age 18 to 80 using a on-spot rapid hepatitis C test. And if that test is positive, it takes 20 to 40 minutes for the test result to come up. They would then have to draw blood and send it into our laboratory or their hospital's laboratory to be sent off to a commercial lab for the virus, the hepatitis C RNA virus. And if that virus is present, then that patient needs to be treated. About 1 out of every 4, 1 out of every 3 patients that gets hepatitis C recovers on their own, but they can get it again. They're not immune. We don't have a vaccine, and getting the infection, even if you recover, doesn't make you immune. But 2/3 to 3/4 don't recover, and it becomes chronic and slowly leads to scarring of the liver and liver cancer. So what the study wants to do is we want to see if persons who are treated by the community health aid via telemedicine with us that have hepatitis C have the same high cure rate that we're getting in our liver clinic. And if we can show that, this would be something to say, okay, this program can be expanded throughout Alaska and also in other parts of the country and the world where we don't have licensed providers, PAs, nurse practitioners, or physicians that are present that can treat patients. So we've actually got funding from a pilot study from CDC to treat 10 to 12 rural communities, and we're selecting those communities now. We've got some of our partners tribal health organizations are really interested in participating. And then we've applied for what's called a PCORI grant. It's part of the Obamacare program. And if we get that grant, we would have enough money to treat 40 communities, and we would be able to tell how effective this program really is. So on-site testing would be with a test called OraQuick, which is a rapid test for hepatitis C. It's waived, it's CLIA waived, it's billable. In other words, even though we get funding for this study, the tribal health organization can bill for that test. If the person has insurance or Medicaid, we get the results in about 20 minutes. And if it's positive, they'll need to have a blood draw sent to the Alaska Native Medical Center or their nearest commercial lab that can do this test. And here's just a picture of the OraQuick test. It's a finger stick, and they put it onto a little device there, which goes into a little cartridge, and then it reads out the result in about 20 minutes. So the Yukon Flats folks and their tribal council has given us letters of endorsement. They're very eager to apply. So what we're going to do is we're going to take the communities, the health aid practitioners, we're going to get not only the tribal approval and the IRB approval, but also the approval of each community council. And in those communities that want to participate, we would bring the community health aid practitioners in to a meeting, and we'd have a 1.5-day training program. We'd bring in also all the providers from that region and also some tribal leaders so they can be there and watch us and ask questions and be involved as partners in this. And then in the communities that are going to participate, we'd screen all adults one time with the AuroSure test. And this would include both native and non-native persons. We would not want to leave out people in the community who are not Alaska Native in these rural communities. And then we have an incentive with some Visa gift cards for the health aides because it's going to involve extra work for them. And then they would have to draw blood if the test is positive. And then a person would be offered treatment via monthly telehealth visits if they want to participate. If they don't, they're free to go to the nearest tribal facility and get treated by that facility. And then the regional provider would fill out the prior authorization forms to get the free drug or to write a prescription for the drug through Medicaid, for example. So every person can be treated at no or minimal cost to the tribal health organizations because they can bill for every bit of this, bill for the screening, bill for the treatment. And if they don't have insurance, the treatment comes for free, and we will furnish the kits for the initial testing at no cost to the tribal organizations. So and the information on getting the drug for free is listed on these websites. And we purchase the drug through the VA system at about 75% of the amount that Medicaid reimburses. So the revenue flow is on the positive side rather than the negative side. And again, if they don't have insurance, they can get the drug from the drug company for free. So in conclusion, we're proposing to conduct a study after obtaining IRB, tribal, and community approval to test all adults living in rural communities who want to be involved for hepatitis C, and if positive, offer treatment, the same treatment we do in our liver clinic and the tribal health organizations do in their hospitals and clinics, by overseeing the community health aid practitioners via telemedicine with us in Anchorage. And then we'll compare the cure rates that we obtain in rural communities to that of the cure rates in the liver clinic, and we predict that there won't be a difference. In fact, it's very possible that it could be higher in the rural communities because we do have some people, a few people, maybe 10% that don't come back for the full treatment, and they would be easy to track down by the community health aid practitioner in the community, much easier than we can track them down. So they may actually do better than we do. So that's my talk, and thank you very much for your interest, and I'd be happy to answer any questions at this time.
Thank you, Brian. I'm looking through the chat box. I don't see any questions posted. There is one comment from Lucinda Crow. It says, on a side note, thank you, Dr. McMahon, for your service to the Alaska Native Hospital and serving the population. It's a nice comment.
Oh, thank you. And it's my pleasure. I just enjoy working with Alaska Native people very much. They're wonderful people to work with.
So,
great ideas for things we should do.
Ricky Peters asks, it says, great project, Brian. What is known about reinfection, I believe, of hepatitis C? I believe that they meant reinfection.
Well, reinfection can occur. You're not immune if you get cured from hepatitis C or if you got infected and happen to recover. And if you get reinfected, usually we have to do the same thing. We treat you with the same drugs. We do have backup drugs that also are oral and safe we only use because they're more expensive if somebody fails treatment or if they get reinfected, and we test them for resistance to one of the compounds that's in the original drug we used. We would use one of these backup drugs. But everybody we've retreated that has taken the full course of treatment, we have not had any failures to my knowledge.
Lucinda Crow asks, what is the percent of patients who do not complete the treatment course?
Well, it's probably somewhere between around 5 to 10%. Now, we don't know for sure on some of these patients because they pick up this. Usually we use an 8-week therapy course. They pick up the second box and then they don't come back for the follow-up visit. So what happens is they finish the course of the drug, and we see them every month, and we would do that on telemedicine. And then when they finish, they feel a lot better. And sometimes they just say, oh, I'm done. I took my medicine. I'm not going to come back. And we don't get them back to get the test of cure, which would be 12 weeks after they finish treatment. We would then test them for virus. And if it was negative, we would tell them they're cured. And as long as they didn't have any scarring in their liver, when we did our FibroScan test, we would say, we don't need to see you again in the liver clinic. You're done with hepatitis C. And we found that we've had patients that have taken the medicine for a month and then they've stopped and they haven't finished and they come back 3 or 4 months later. About half of those end up getting cured and about half of them don't. So we have to retreat that half. So those are kind of the expectations that we see.
So another question, Jason Burkhead asks, he says, thanks for the great talks. The question about UDCA makes me wonder about comorbidities with gastric cancer or maybe even H. pylori in non-responders. Perhaps some of the gut microbiome changes promote UDCA biotransformation. Are there enough cases to ask the question?
Yeah, we've got about 100 people with primary biliary cholangitis around the state. And they get a letter to get their blood drawn every 6 months. We try to see them at least once every 2 years in clinic and either in one of our regional clinics with tribal health organizations around the state or here in Anchorage. And we have one nurse that devotes her time to following these patients along with autoimmune hepatitis patients. And she keeps a pretty close eye on them. So we certainly could get, samples to look at the microbiome if that was something that might be of interest. Thanks, Jason, for that question. And then I see Ricky Peters asked about combined intervention. Absolutely. We are really, and one of the things in our training program that we're developing for the health aides, it's modeled after a training program which we put on for providers in Anchorage, Fairbanks, the Kenai Peninsula, and in Juneau. And it includes teaching about education about avoiding Hep C infections, about opioid abuse and the treatment of that, and HIV and other things that I think are really important to include in the educational program. So we have handouts with that information also. So we are very cognizant of the need to do prevention because we don't have a vaccine, and to do education that would help persons with some of the other difficulties that they are encountering with hepatitis C.
I don't see any other questions. I'll go ahead and also type in our website for folks to access if they have any questions about if there's any providers or nurses or any patients out there that you'd like to direct towards the hepatitis program. We have a website and are always available to answer any questions as well.
And I might add that Danny Varney, our host, is the project coordinator of this project. She's the one who's putting it all together, and she, of course, grew up in St. Mary's, Yupik, and it's really exciting to have her involved. She's a very competent and organized person, and I wouldn't be able to do this without her.
Brian. And thank you for the talks. I believe that I don't see any other questions in the chat box. And moving on, I believe, is the plenary session after this about climate change, if I'm mistaken. But yes, like I said, you can always contact us at our website for any questions.